Good afternoon, everyone. I'm Dr. Shannon Zank. I'm the director of the National Institute of Nursing Research, and I am excited to welcome you all to today's NINR Director's Lecture on Maternal Health. So today's lecture will be recorded and made available through our website, ninr.nih.gov. Closed captions are available and may be enabled at the bottom of your screen. You can use the Q&A module to ask questions at any time during the webinar, but we will hold questions until the end and try to get through as many as we can. We're also pleased to be offering continuing education credits for today's webinar. So stay with us until the end for more information and a QR code to scan to respond to an evaluation and obtain credits. So at NINR, we are committed to leading nursing science to solve pressing health challenges and inform practice and policy, optimizing health and advancing health equity into the future. One of the main goals of the NINR Directors Lecture Series is to highlight research that exemplifies NINR's research framework. So our first lecture this year addressed climate change and health, and in May, we focused on firearm injury prevention. Today, we're here to discuss maternal health. So maternal health is a priority for us at NINR, not only because the US has some of the worst maternal health outcomes among high-income countries, but also because there are enormous disparities in outcomes, even within the United States. So here are just a couple of numbers. Last month, a new report estimated the US maternal mortality rate to be 22 out of every 100,000 live births, a rate more than double and up to triple that of other high-income countries in the analysis. Non-Hispanic Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die of pregnancy-related causes when compared to their white, Asian, Pacific Islander, and Hispanic counterparts. While the disparities are very clear, the solutions are not. Maternal health is a complex topic with many contributing factors. So we at NINR are confident that nursing research can discover and deliver solutions to reduce inequities and improve maternal health outcomes for everyone. That's why we started the AIM initiative, which supports research on interventions that integrate strategies in 3 domains: healthcare access, healthcare quality, and social conditions within the context of supportive care persons and services such as doulas, community health workers, social service providers, and patient navigators. So under this initiative, we're supporting a number of studies already, for example, that look at the impact of integrating community-based patient navigation on maternal care for Black women. NINR is also bringing nursing research to the table on this issue as a co-chair with NICHD and ORWH of the NIH Improve Initiative. Now, the Improve Initiative supports research to reduce preventable causes of maternal deaths and improve health for women before, during, and after delivery. It includes a special emphasis on health disparities and populations that are disproportionately impacted. Improve has a number of ongoing research initiatives. This includes last year funding 12 maternal health research centers of excellence. So as you can see, NINR is very invested in this area, and we are thrilled to highlight the work of one of our researchers in today's lecture. So today I am very pleased to welcome Dr. Mahasen Mujahid, who is a leading authority on the social and structural determinants of maternal health and cardiovascular inequities. She is the chair of the Division of Epidemiology and the Lillian E.I. and Dudley J. Aldous Endowed Professor at the School of Public Health, University of California, Berkeley. Dr. Mujahid serves as the principal investigator of the Social Determinants Core for Rural, a longitudinal cohort study examining heart and lung health in a diverse population of adults in rural Appalachia and the Mississippi Delta. Her work focuses on developing a comprehensive database of multi-level social factors and conducting rigorous investigations into their relationship with health inequities across the life course. So welcome to Dr. Mujahid. We are so pleased you could join us, and I will turn things over to you.
Okay, thank you so much for the lovely introduction. I just want to confirm that everyone can hear me okay?
Yes.
Okay, great. And I am always delighted to think of Dr. Zink, who I've admired for a long time. And I was just telling her earlier that I remember when we were in graduate school together at the University of Michigan, and I read one of her early papers in 2006, where she was instrumental in shifting the conversation around sort of fruit and vegetable intake and consumption to food access and the structural barriers that are denying some communities food access. And so it's just been a pleasure to watch her career unfold. Next slide, please. So what I thought I'd do today is really try to align my talk with the bold strategic plan that NINR has set forth. And what I want to do is to emphasize the importance of health equity. I want to talk about the critical role of social and structural determinants in achieving health equity. And then finally, I would like to talk about how this work can lead to population and community level solutions. And so specifically what I'm going to do in terms of the overview of my talk, I'm going to begin with describing the current moment that we find ourselves in where sort of health equity and social determinants work is really central to population health. And then talk a little bit about my work in maternal health inequities. And in doing so, I'm going to highlight 3 key principles that are really important as you engage in health equity research, which is creating inclusive teams where you work together to collaborate on a shared language and common goals, to really do intentional research where from every step of the process, you think about the problem to impact and you emphasize rigor in every step at every stage. And this isn't just empirical rigor, but also conceptual rigor, theoretical rigor, and other forms of rigor. And then finally, that the comprehensive solutions that we seek really require us to partner with marginalized communities to really implement multi-level and multi-pronged strategies. Next slide, please. So we find ourselves in this moment where there is a global call to action, and this global call is really to address social and structural barriers as root causes of health inequities. Next slide, please. And instrumental in this moment was the year 2020. It was really pivotal in centering health equity, also in centering racism and centering the social determinants of health. So we started off the year, obviously, with a global pandemic. And with this global pandemic, we witnessed a massive loss of life, but we were living through the numbers. So we were sort of understanding the daily statistics around reported new cases, hospitalizations, and deaths that represented the faces of our loved ones, the faces of our neighbors, and the faces of our colleagues and coworkers. And we also witnessed the disproportionate burden of COVID-19 related deaths across indicators of social marginalization. So we saw a disproportionate burden in racial and ethnic minoritized populations, individuals with sort of few access to socioeconomic resources, and then also this geospatial variation in the burden of COVID-19. Next slide, please. Next slide, please. I'm not sure if the next slide is coming. Oh, sorry. Can you go back to the last slide? Something's not. Okay, that's the slide. Thank you. And so when we actually saw the numbers, what we realized is that our worst nightmares were really sort of visualized in terms of loss of life expectancy. So here we see in 2021, life expectancy by race and ethnicity. And we see that there were 4 to 6 years of loss of life in American Indian and Alaska Native populations, as well as Black and Hispanic and Latino groups in the United States. And this kind of loss was similar only to 1943, for example, when we saw a massive loss from World War II, and then sort of the most loss that we saw in 1918 during the influenza pandemic. But this really sort of brought those numbers that we were seeing on a daily basis as the tickers were happening with hospitalizations and deaths to really show the impact of COVID-19. And then also we know that the social and economic burden of COVID-19 means that there's sort of going to be continued inequities that sort of persist after this global pandemic. Next slide, please. So the other thing that happened in 2020 that made it a pivotal year is that in a time where we were extremely vulnerable, that we had a heightened state of anxiety and concern for humanity, we also witnessed the public viewing of the killing of George Floyd. And that really sort of led to a resurgence in the Black Lives Matter protests and also global support and solidarity for this cause. And so we also from that saw this bold leadership with health leading sort of health agencies, funders, organizations, and institutions really declaring racism as a public health crisis. Next slide, please. So you, I think you went 2 slides. Previous slide. Okay, I'm not exactly sure what's happening. It seems like we're forwarding too many slides at a time. The previous slide, sorry about that. Previous slide. Perfect. Okay, so you can see here just an example of some of the statements that were coming out. The American Public Health Association actually sort of released this declaration of racism as a public health crisis before the year 2020, but also then sort of led the way in that year to invite other organizations to sort of come forth and speak up around racism as a public health issue. You also saw the director of the CDC declaring racism as a serious public health threat, and then other organizations from AMA to the American College of Physicians and other sort of leading health organizations. Next slide, please. And then we can see here that there was a joint statement in relation to obstetrics and gynecology on this collective action of addressing structural racism. And in this statement, they note that as our nation confronts systemic racism and consequences of persistent inequities and disparate outcomes in healthcare, that it's really our responsibility to sort of commit to a culture of change, commit to eliminating racism and racial inequities that lead to disparate health outcomes, and then also a commitment to promoting equity in women's health and healthcare. Next slide, please. So this has led to an exponential increase in not only funding for sort of work on structural racism as well as social determinants, but also scholarship in this area. And you can see that after 2020, there's this sort of exponential increase from a PubMed search looking at racism being sort of discussed as a title or abstract. And you can see that this has facilitated an opportunity for research teams to really do health equity work where we're focused on the structural and systemic issues. Next slide, please. So even though this moment feels big and it feels new and it feels sort of critical in the evolution of social determinants and health equity research, I want to make sure that we know that we stand on decades of work that have sort of tried to center health equity, tried to center social determinants as well as structural determinants. So back in 1968, we need to be reminded of the Kerner Report, which was commissioned by President Lyndon Johnson after the summer of 1967. And at that time, we really saw this national outcry across American cities in relation to the treatment of Black Americans. And this report was really designed to figure out why it happened, what can be done to prevent it from happening again, and really sort of provided language for racism being a fundamental cause of, in this case, death, but also just in terms of overall conditions in the United States. And so one of the statements from this particular report was that race prejudice has shaped our country decisively and it now threatens to affect our future. So again, foreshadowing the moment that we're in now, we saw early work in 1968 sort of leading to this moment. And then outside of the United States, there was seminal work that was going on to really expose sort of the world sort of in thinking about social determinants of health, right? So thinking about how factors other than biology, other than genetics, factors that are related to relive, grow, work, play, age, being key drivers of our health. And so one of the early reports in 1980, the Black Report, highlighted these kinds of social sort of inequities in the UK, and then followed subsequently in 1998 with the Atchison Report. So we had sort of work happening outside of the United States, really giving us language for social determinants and defining social determinants. And that work would also be instrumental in the World Health Organization really sort of making a commitment around social determinants and addressing sort of those determinants to improve population health globally. And then in the United States in 1985, we had the Heckler Report, which raised national awareness of the specific health inequities that we saw based on race and ethnicity. And it really emphasized how, despite at that time, how there was this gain in scientific knowledge and medical discoveries, that it really wasn't benefiting all members of our society. And so this really allowed us to put a lot of accountability measures in place, surveillance systems, changes to our healthy people goals, sort of and on, to really allow us to take advantage of the moment that we're in today. Next slide, please. Okay, so now I'm going to transition to talking about my research sort of program in maternal health inequities. Next slide, please. And I always want to start by thinking about sort of those real images and real stories, because that really makes the data come to life. And so these are images of Black women who have been at the heart of the maternal health crisis in the United States. You can see their names listed there. And I really sort of entered into this work after having my own sort of experience of pregnancy-related, a sort of adverse pregnancy-related event. And so these reflections, as well as sort of this national crisis that we're in terms of maternal health, sort of is the lived experience that I'm bringing to the work that I do in trying to really achieve maternal health equity. Next slide, please. And I really love this quote that really sort of forces us to remember that the Black maternal health crisis is the American maternal health crisis, that there is no delineation. If we can fix this problem for Black women, we can fix it for everybody. So by centering Black women, we in no means are ignoring the other inequities that exist based on rurality, based on disability status, based on a number of other indicators, socioeconomic resources, et cetera. But it invites us to think about solutions that can be common solutions for all of these health inequities. Next slide, please. So we know that there is data behind this crisis. Dr. Zink mentioned some of that data. There have been numerous reports from the CDC and other national reports really emphasizing sort of this maternal health crisis in the United States, as well as the disproportionate burden of pregnancy-related mortality and morbidity among racial and ethnic minoritized populations. Next slide, please. And so the work that I've been doing with a team that I'll talk about in a minute really focuses on severe maternal morbidity, really trying to go beneath the iceberg to think about sort of those near misses or those sort of really severe related events that could have led to mortality, but didn't, and how we can sort of really understand the inequities that exist in severe maternal morbidity, as well as the social determinants and structural drivers of these inequities. I see we're already on the next slide. So the, yes, thank you. So the first key principle in approaching this work is trying to create an inclusive team, as well as an inclusive research approach. And this is something that I've been able to do with a team of wonderful collaborators. Next slide, please. And you can see here that at the core of this collaboration was really our intentionality around making sure that we had diverse lived experiences. This includes individuals from historically racialized backgrounds and other indicators of marginalization, from disability to socioeconomic status. We also wanted to have this representation in terms of the leadership of our team, as well as our trainees, so that we're not, so that we're really demonstrating our commitment to centering diverse experiences and sort of diverse perspectives that people bring to the research. We also are very diverse in terms of the disciplinary backgrounds. We have epidemiologists, gynecologists, nurses and nurse scientists, biostatisticians, et cetera. And we believe that that really adds richness to the work that we do together as a team. Next slide, please. We also really wanted to be intentional about establishing an inclusive research approach. So in order to be intentional about this, we really needed to sit down and think about the principles, the core principles guiding the work that we do together as the team. We talked about our commitment to language and ensuring that all identities are represented and honored through the work that we do. And then also recognizing that sort of best practices around language can change over time, and that it's our responsibility to update these best practices as we sort of grow and evolve in our understanding. We talked about equity and our principles around equity, and really sort of moving away from equality and thinking about sort of really centering the marginalized communities that are disproportionately burdened by historical injustices and contemporary health inequities. We talked about the humility that we want to bring to the work that we do, talked about sort of evolving cultural and community preferences and making sure that we are adaptive to those sort of changes over time. And then we talked about accountability, how we hold each other up as a team, how we have difficult conversations, and how we sort of support one another in really sort of committing to this program of health equity research. Next slide, please. So the next key principle that sort of is important as you're engaging in this work is to really be intentional in the research. And I talked about sort of the need for this sort of rigor around the research, but also really being intentional about what is the problem you're trying to solve, the sort of conceptual and theoretical support for the work that you're trying to do, and really incorporating that throughout the process as well. Next slide, please. So this represents a conceptual framework that our team sort of put together and then also provided to the broader community to really think about how we understand pathways of severe maternal morbidity and its inequities. And what you can see is that we really wanted to move beyond just this sort of understanding that SMM has to be approached from a life course perspective, that we understand their clinical precursors and health-related factors, but also emphasizing structural and social determinants of health as being critical to our path towards sort of health equity in terms of SMM. And then also really explicitly sort of naming and acknowledging the historical context, talking about intergenerational trauma, talking about sort of structural racism and other historical insults that have shaped the current state of SMM disparities. And then the other thing that we were really intentional about doing is grounding the work that we're doing in the frameworks and theories that we think are critical. So we grounded it in reproductive justice. We grounded it in sort of life course and intergenerational perspectives, multi-level frameworks, and also community engaged research that really emphasizes racial equity. And so all of those things are really important for us to mention. In the paper, we go into detail about other theories that we incorporate: eco-social theory, critical race theory, socio-ecological model. But so really trying to be intentional about best practices in shaping the research that we do together as a team. Next slide, please. So early on in the work, we looked at and tried to really understand in the state of California, which is the work that we're sort of doing, what were the sort of trends in SMM in California, as well as the racial and ethnic disparities in the state of California. And you can see here sort of the same kind of data and patterns around sort of Black individuals being disproportionately burdened with severe maternal morbidity are apparent in the trends over time. But then also some of the other disparities are apparent. And in a state that's as diverse as California, we really have an opportunity to understand some of the other sort of racial and ethnic groups that are usually compromised by small sample size, so we can really better understand the disparities and the drivers of those disparities for these other groups as well. So that's something else that we've been committed to as a team. Next slide, please. So early on, we were really interested in sort of really understanding the landscape of what had been done in relation to social determinants of health. So there was a review that came out in 2020 that sort of found 83 studies on social determinants of health. And this was in relation to any sort of maternal health related event, mortality or morbidity. And one of the things that we noticed was that the majority of these studies were describing the racial ethnic disparities that I just talked about, were describing differences based on maternal health and payer status, and very few were addressing a broader set of social determinants, including those that are operating at multiple levels. And so there was very little work that was happening around understanding the role of neighborhoods and shaping sort of outcomes in SMM. And those studies had focused sort of primarily on county and zip code level data without more granular information about how aspects or features of neighborhood environments may be shaping SMM. Next slide, please. So we work to leverage this statewide resource that has been an investment of love, right? So there's a lot of work that has gone into putting this data set together, linking the data from hospital discharge, birth and fetal death records, as well as overlaying geospatial data. We have this information from 1997 to 2018, and we're continuing to update with the latest possible data. And so using this HCI resource has allowed us to overlay a lot of really rich geospatial data so that we can better understand statewide disparities in SMM, and as well as other outcomes as well. Next slide, please. So we work to bring together as much data as possible from a variety of different data sources across a broad number of years, as you saw. And then this continues to be updated. And so as we think about sort of the really key and critical questions that we want to ask, we think about what are the creative ways in which we can access data sources to bring those questions to bear, to actually provide some insight based on the available data. And then we also were intentional about looking at measures that can really lead to sort of policy solutions. And so in the state of California, there's been a lot of work from this Public Health Alliance of Southern California to create this sort of healthy places index. And so being able to show sort of geospatial differences across the state of California using this healthy place indicator is one way that we can then sort of pinpoint some of the potential solutions across these different geospatial differences. Next slide, please. So in doing the work, one of the things that we were really intentional about was trying to figure out what are the principles in doing neighborhood health effects research. And I, sort of have been doing research in this space for a number of years now. And what I'm noticing is that there's this saturation of investigators and teams that now have access to geospatial data. They have, sort of variables that have already been incorporated into their data sets. And so they can sort of add a neighborhood level indicator, sort of similarly to any other individual level indicator, and sort of run a line of code and output some results. And so in a venting session, actually, with my research group, we really talked about how we need to be able to do the work responsibly. And is there some guidance that we can provide to teams as they are trying to engage with neighborhood health effects research? If they're new and they're really interested in sort of these multi-level drivers of population inequities, if they really want to do it in a way that is informed by best practices, what are those best practices? And so that's what we laid out in this particular roadmap, excuse me. So what we are proposing is that you simply ask the why, what, how, and now what. So really being intentional about why you want to study neighborhood health effects and what you think the nature of the relationships of interest are, thinking about the what, sort of what role do neighborhoods play, sort of really sort of clearly defining that in terms of how it's conceptualized, how it's operationalized in a particular research study, what sort of characteristics are you interested in, what are the dimensions that you're interested in, and then also what's the relationship between individual level factors and these neighborhood characteristics, so that you can sort of incorporate that as well into the research question. Thinking about how you operationalize, what's the conceptual framework and the theoretical basis that you're using as part of your research. Also thinking about data source considerations, measurement, and other analytic sort of considerations when you're doing a quantitative analysis. And then finally, thinking about what is the potential research or policy implication of the study, and making sure that you ground, sort of your investigation in those potential and think about and push and think about and sort of those implications. Next slide, please. So in bringing sort of the roadmap to bear, we looked at sort of neighborhood deprivation or neighborhood disinvestment index, which I like to refer to as a better way to describe what's happening at the neighborhood level in terms of the differential distribution of socioeconomic resources. We were able to leverage the statewide resource to show that there are these gradients, sort of environments that have more socioeconomic resources are protected, or those who have fewer socioeconomic resources have are at more risk of SMM. And we can see that that pattern sort of existed overall, but we were also interested in knowing if there was differential impact of neighborhood disinvestment across racial and ethnic groups. So where there's some groups that were more vulnerable to the SMM implications of being in an under-resourced environment. So we have hypothesized that, for example, Black individuals would be sort of have stronger magnitude of associations in terms of NDI and SMM. And you can see here that that hypothesis didn't pan out. And one of the things that it led us to thinking about was, is there a diminished return on sort of increases or improvements in neighborhood socioeconomic resources? So what we think about in terms of living in an environment with more access to resources may not play out equally across all racial and ethnic groups, and that there may be other structural processes that are limiting the potential impact or the sort of SMM impact of these environments, particularly among racially marginalized individuals. So those are some of the hypotheses that we thought about sort of following up on based on this initial investigation of looking at the relationship between NDI and SMM. Next slide, please. We also have done some work to look at rurality and urban-rural differences in SMM. You can see here, this is some work that was led by Dr. Rachel Berkowitz at San Jose State. And one of the things that sort of we've done as part of this work is to really identify these urban-rural differences. So you can see here, looking at a binary categorization of urban-rural, you can see a slight increase of SMM for those individuals that reside in rural areas. Rural areas only represent 5.7% of births in the state of California. So you can see we're talking about a large geographic area, as you can see in the map presented here, but a small number of births. But regardless of that, we see some evidence of disparities in sort of increased risk among rural residents, but that's also driven mostly by sort of individuals in these micropolitan areas. And so when we do more work to bring in the rich RUCA code classifications that look at sort of community share, population size, commuting flows, sort of urban clusters, micropolitan and sort of small urban clusters and small towns, and really brings nuance into those classifications, you can see that a lot of the disparity exists within these micropolitan areas. So we're doing additional work to figure out what might be underlying this potential, increased risk. We know that it's more than just neighborhood disinvestment. We control for that in our models. So we're trying to look at what other things, access to hospitals, et cetera, might be driving those urban-rural differences. Next slide, please. We've also been doing some work to really think about intersectionality and characterizing differential risk of SMM, at the intersections of racial marginalization, weathering, neighborhood spatial disenfranchisement, and individual socioeconomic deprivation. And this is some work that Dr. Eleni Hailu has been leading, who's a postdoctoral fellow at UC Berkeley. Next slide, please. And part of this work is really bringing to bear intersectionality theory. And so this is really an important tenet of critical race theory that originates from Black feminist thought and legal scholarship. And you can see that it really outlines how sources of marginalization from racism, sexism, classism, et cetera, interact with one another to create unique forms of oppression that are greater than the sum of the individual parts. And so bringing this to bear, we sort of investigated sort of the differential risk of SMM across these intersections presented here. Next slide, please. Also, can I get a quick time check? I realize that I didn't start my timer, and so I just want to make sure that I'm respectful of time.
About 7 minutes left.
Okay. Thank you very much. Let me just start that. now? Okay, so you can see here that in these models, looking at the predicted probabilities of the intersection of racial marginalization, we can see some interesting patterns. So for example, here we found that Black birthing people that were thought to be better off, so that is to say that they were younger and had college degrees, had a higher risk of SMM than white birthing people who were thought to be worse off. And that's to say that they were over the age of 35 and had less than a high school diploma. And so you can see here, when we do this intersectional approach, it really identifies sort of subgroups that are disproportionately impacted by SMM. Next slide, please. You can also see here in those same models, we found that Black birthing people thought to be better off. And this is in the case of, I'm sorry, I'm gonna make sure I'm on the right slide. 1 second. And this was sort of Black birthing people who were younger and resided in neighborhoods with less disenfranchisement had a higher SMM risk than those white birthing people who were older and resided in the most deprived neighborhoods. And so you can see again, this disproportionate impact at the intersection of these different categories of social marginalization. Next slide, please. So from there, Dr. Hailu has done work to conceptualize structural racism as this sort of defined as a totality of ways in which society fosters racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, healthcare, criminal justice, et cetera, and really sort of thinking about how it may affect maternal health. So how these systems reinforce racial hierarchy, how they reinforce the differential distribution of resources and access, and then how, as women are navigating these psychosocial resources, such as adaptive coping and social support, that they are doing this within the context of these multifactorial and multi-level stressors. Next slide, please. So one of the things that Dr. Hailu has been working on is trying to develop this sort of multidimensional measure of structural racism. In this particular paper, she looked at sort of annual county level jail incarceration and sort of Black-white differences in incarceration from 1997 to 2018. She obtained this data from the Vera Institute of Justice that provides incarceration trends data and was able to show this increased risk of SMM in those individuals that were sort of residing in areas with the highest level of inequity. So the highest level of sort of Black incarceration relative to white incarceration in those counties, excuse me. And then that sort of association also existed as well for the other groups that you see listed there, particularly the Hispanic and Latino birthing people in the state of California. So trying to move beyond thinking about sort of neighborhood disinvestment, but what are the structural drivers of that disinvestment? And then looking at sort of these individual components before building a multidimensional measure of structural racism and its implications for SMM. Next slide, please. There's also been work done by Dr. Xing Gao, who's a postdoctoral fellow at UCSF, really trying to look at neighborhood trajectories of redlining, segregation and gentrification and its implications for SMM. Next slide, please. Some of the initial work has looked at sort of redlining using the Mapping Inequality Project at the University of Richmond that provides sort of maps across the country, a little over 200 of these maps, where determinations were made about investment, deeming some neighborhoods desirable and the best neighborhoods for this investment, and then some neighborhoods as being hazardous, which sort of refers to the term redlining. And you can see here, based on these initial investigations, that among Black birthing people, there was increase of SMM for those individuals residing in historically redlined areas, and the same sort of associations existed for Hispanic birthing people in the state of California. Next slide, please. Also, Dr. Gao is doing work to look at gentrification in health. So looking at sort of this process in which historically disinvested neighborhoods experience private sector-led and government subsidized development, resulting in the improvement of physical infrastructure, but the displacement of long-term marginalized residents. and showing important links between sort of gentrification and S&M as well in the state of California. And the next steps of this research will be to create these trajectories from redlining to current day gentrification to really better understand how S&M risk varies from historical to contemporary sort of indicators of sort of structural factors that are geospatially manifested. Next slide, please. So all in all, our work is sort of moving forward. We're working to develop topologies and multidimensional measures of these structural drivers. We're looking at mechanisms and sort of exploring potential impact models to understand sort of how changes in these various factors might sort of lead to changes in maternal outcomes. We're looking at the incorporation of these social and structural determinants in sort of maternal health initiatives in the state of California. And then we're also sort of guided by the desire to develop multi-level interventions to address social and structural determinants of maternal health inequities. Next slide, please. And then finally, I just want to mention that another and sort of important key principle is really doing this work in a comprehensive way that leads to community-driven solutions that includes important community partnerships. This work can't be done without that. Next slide, please. So part of the work that we're doing, and this also extends beyond our severe maternal morbidity research team, but includes members of our team to really do really deep, sort of deeply engaged community work where we sort of work to set the research prioritizations. You can see here this work has been led by Dr. Andre Linden and also has been done by some of our junior faculty, such as Dr. Carissa Tucker, who's on faculty at the University of South Carolina. South Carolina, excuse me. And you can see here that one of the things that we've established is a community advisory board where we have 11 members from 4 states, from those communities that are most impacted by S&M, those communities that experience marginalization, and to really incorporate them as part of the process of not only the research investigations that we're doing, but also understanding their research priorities and how we can have our work align with those research priorities. Next slide, please. Sorry about that. Let me just stop this. It's the alarm. And so then finally, I just want to say that the work that we're doing is also in collaboration with many people across the country, many research teams across the country. Dr. Zink mentioned this Approve initiative and the 12 sort of teams that have been funded across the country to really work on sort of this goal of maternal health, sort of health equity, and the diversity represented in terms of geospatial diversity, sort of investigations of urban-rural differences, investigations of those racially marginalized populations that are disproportionately burdened by maternal mortality, and really sort of working together in partnership with communities to think about and implement sort of viable solutions. Next slide, please. So with that being said, I just wanted to thank you for your time, to also remind you that as we work together to achieve maternal health inequity, we want to make sure that we're doing it in inclusive teams, that we're really intentional about the research and the problem to impact sort of spectrum of the work that we do, and then working together with communities to think about comprehensive solutions. So with that, final slide, thank you for your time and look forward to the Q&A session. Thank you.
Thank you so much, Dr. Mujahid. That was just fantastic. A number of things, stuck out to me, including just how thoughtful your approach is, how systematic in terms of understanding the health issue, and then systematically moving the science forward in a rigorous way. Really considering social and structural factors and paying attention to equity in your design as you do it. So thank you for your work, and thank you for sharing that really nice overview with us. So I would like to invite our participants on the webinar to ask questions using the Q&A function in Zoom. We'll try to get to as many as we can. In addition to the Q&A feature, we'll also be conducting a poll, which is coming up right now. So we've prepared a couple of pre-selected questions that we'd like you to vote on. Which one you'd most like us to ask Dr. Mujahid? So the poll is up. You can see the questions there. If you have technical issues, put them in the chat. So here they are. Your work includes a focus on multi-level determinants of health disparities. Can you talk a little bit about the challenges and opportunities there? Let's see. I'm going to change options 2 and 3. So you'll have to pay attention to the new questions I'm going to throw out there. So there's been increasing momentum in health equity research and interest in, interest in exploring structural drivers of health inequity since the pandemic. What do you see that is missing from the field? And what do you hope to see more of in future directions in this research? And then currently, what are 2 to 3 emerging advancements or innovative approaches you see in studying structural drivers of health inequities? So specific to maternal health or other health outcomes, are there ongoing projects or emerging work that is especially exciting to you? So if you can keep track of those questions, go ahead and vote which question you're most interested in hearing from Dr. Mujahid about. So I will wait for a minute to get those poll results. I am sure it is going to happen any moment. We'll get them. Aha, I see the results now. So number 2 won. It was very close between 2 and 3. So just to remind us, question 2 was, there's been an increasing momentum in health equity research and interest in exploring structural drivers of health inequity since the pandemic. What do you see that is still missing from the field? And what do you hope to see more of in terms of future directions in research?
Yeah, so I think one of the things that I've noticed is, and it's a good direction to move in, which is this emphasis on the interventions, right? So we're in this sort of era of health disparities or health equity research where we really want to be thinking about the solutions, those viable solutions that we can implement, and the kinds of interventions that we can bring to bear. And I think one of the challenges in doing so is that, sort of developing compelling interventions require us to focus on a very specific, targeted, well evidence-based strategy, right? So we want to isolate that it's the food environment that's impacting, sort of X health outcome, and then we want to intervene on just the food environment. And what's happening is that we understand that these things aren't operating in a vacuum. So there's not the environment where food is the only, or limited access to food is the only driver of the disinvestment that exists in that environment, or the ways in which it can create sort of more stress and sort of processes that lead to health inequities. And so our solutions can't focus on sort of this thing as if it operates in a vacuum. So I think we need to see more of these multidimensional, multi-pronged strategies that are getting at multiple social determinants operating at multiple levels. Now, it's definitely challenging to do that. And that's why we need sort of these comprehensive research teams. We need data hubs. We need centers of excellence, as we've seen, to really do this work sort of nationally collaborative in order to really bring the evidence to bear of how we do these interventions, how we implement them, and then how we scale them up sort of for more communities and more populations. So that's one thing that I'd like to see us do in the future. And then I just remind us that just because we really want to see actionable solutions, it doesn't mean that we don't need more observational research. One of the benefits of this research is that there's still so many unanswered questions that we don't know, questions that we're just now really receiving the funding to be able to answer in a rigorous way. And so I'm reminded of some efforts at NIH a number of years ago to really look at the portfolio of funded research on social determinants. And at that time, it was something like 5% of the funded grants were on social determinants. And then things like the Ginther report, we know that sort of there are racial and ethnic disparities in what investigators are getting funded to do that research. And so there's been so much work at NIH to really increase awareness about this underrepresentation of funding, create more targeted funding opportunities, RFAs and programs of research, centers of excellence. And that has really been instrumental in allowing investigators the resources that they need to answer these important questions. And the work that comes from this observational work can really be done in an intentional way to inform next steps and solutions that we want to sort of work together in partnership with communities to implement.
Yeah, thank you for that. A lot of really valuable insights there. Thank you. Well, the questions are rolling in, but feel free to contribute questions through the Zoom. Let me get started. There's a number already. So first, what is your thought process about bringing value back to the women who contributed all of these sensitive data to the study, including residential history?
So bringing value back, I guess I'm wondering what that means in terms of whether they've lost value to begin with. I do acknowledge that there's a very complicated history with the way in which we have exploited marginalized communities in the spirit of scientific inquiry and investigation. And I think we have done a better job more recently of exposing those kinds of injustices that have happened, and also partnering with communities to make sure that we're doing work that is really centering their voices and their experiences. Now, in order to really do this work, it does require resources and investment in the community engagement core and sort of function of the research team and the research aims. And I think we've been doing a better job of incorporating that, also because NIH is demanding it and other leading health funders are demanding it. They're actually explicitly in the RFA saying, we're not going to fund this if we do not see a strong community engaged core, evidence of strong partnerships, evidence of reciprocity, sort of, and other sort of principles that need to be brought to bear in order to do this work in the right way. So I think that when we do that and when we're intentional from the very beginning, that we never they don't have to lose value because we've been centering their voices and their experiences from the very beginning.
Yeah. My next question from the chat is going to build on that a bit. You talked about community engagement and the importance of that in this work. And how can community organizations really work or partner with you or other researchers to increase the impact of what you're doing?
Yeah, I mean, I think, one of the things that I have appreciated is that communities have started to really empower themselves with what investigators need to do to engage with them. And so I think sometimes what happens is that we are trying to do the work in a performative way. And we need to be more intentional about the community benefits that we are bringing to bear. What are the resources that our institution will bring to the community organization? What are the long-term sustainable partnerships that we will bring to bear? And then how we can sort of really put in the sweat equity to demonstrate that we are trustworthy, to demonstrate that we have a long-term commitment, and to demonstrate that we're willing to sacrifice our resources for their benefit. And so in some of the work that I'm doing around cardiovascular health disparities in the rural South, one of the things that we had to think about as a team of investigators that exist across 17 institutions, many of which are not located in the states that we're actually recruiting from, is that we needed to have real presence. Sort of having strong sort of community advisory boards, but also having our investigators come to community events that are not related to our study. So when there are extreme weather related events, how are we buckling up and sort of showing up to serve? Sort of how are we really identifying resources in the community or bringing more resources in the community? How are we hiring locally for the study? Sort of staffing our sort of mobile examination unit and our sort of outreach workers with local residents from the communities that are impacted. And I think the more that we have worked to establish that presence, the more trust we build in the community, and then the more we can have a sustainable relationship as we work to, sort of together to do the work.
Thank you. Well, you've inspired me and you're inspiring others on this call because there are several questions about how to get started in this type of work, how to make a difference in this, field and related areas.
Yeah, I mean, I think the important thing is to know that there's not any one thing that any sole individual can do to do this work in a meaningful way. It requires teams. And even when you think you have a diverse and sort of representative team, you still need to do more work to make it even more diverse, more inclusive, sort of really centering on the margins. And it's a continuous process for the entire time that the work is going on and beyond, because we always learn, we always grow, and we have to adapt to our improved understanding of sort of the best practices and successful collaborations. So I think finding a team of people at your local institution, even nationally, I think people are open and excited when sort of investigators are interested in collaborating. This sort of partnership that I sort of have joined with individuals at Stanford University, NYU, and other institutions, it really was from a random, sort of connection where yes, a senior colleague of mine knew about some of my personal experiences with an adverse sort of pregnancy-related event, had watched my journey of healing, and had, sort of talked about how there could be important work that I could do to sort of increase representation of research around social and structural drivers of maternal health inequities. And that there's this excellent team that I could sort of, she introduced me to, and they embraced me, and then we've been building together ever since. And so, one-off conversations, sort of getting the word out that you're interested in this work, and really networking can be instrumental in providing a foot in the door to do the work.
Yeah. Thank you for sharing that personal experience. It is often those things that can really motivate our work and keep us going in the difficult times. So thank you for sharing that with us. One of the things, of many that I thought was great about your talk was your focus on intersectionality and really highlighting how that matters. It does tie in really perfectly to an initiative we have out now that I wanted to mention and make sure people were aware of. It's called the Axes Initiative, and it really is looking at intersectionality and understanding better how that plays out in terms of health disparities and health outcomes. So we'll share a link in the chat for people to be aware of that initiative. So thanks for that. So one of the comments is you mentioned, right, the importance of diversity, the importance of diverse perspectives. And you mentioned you had nurses and nurse scientists on your team. So wanted to hear you reflect a little bit about that, your own experience there, and the role that nurses and nurse midwives can play in terms of the solution for this really complicated health issue.
Yeah, I mean, there are just so many experiences that I've had, but one that comes to mind for me is that, especially sort of epidemiologists who can really get into the weeds of the methodological sort of challenges of something, for example, of how we define SMM. And we can go on and on and on about which set of indicators, and this study had 21, this study had 18, this study had 7, and are we really capturing the most severe indicators, and are we really sort of capturing the aspects of SMM that lead to specific pathways and mechanisms to various maternal health outcomes and mortality related events. And we can just go on and on and on. And one of the things that I appreciate from our nurse practitioners and scientists is that they really talk about the experiences of the actual birthing people who are coming into hospital systems who don't know anything about those definitions, right? Who are experiencing, sort of these adverse events, and who need the support to get through it. And those are the people who we're trying to serve. And as much as we can get lost in which definition is the best definition, across all of these definitions, the disparities are stark. So if we spend all of our time focusing on the definition and the nuance and the methods, and we forget about the suffering and the disproportionate suffering, then we're never going to really be on a path towards maternal health equity. And so that's one of the perspectives that I think is really important that our nurse practitioners and scientists really bring to the work that we're doing. And then they have really done a lot of work to develop our community advisory boards, to sort of partner with sort of diverse birthing persons across the country, and to center their voices and represent those voices on our team. And so it's just been really invaluable to the work that we're doing.
Yeah, it's great to hear you talk about from an interdisciplinary perspective, how valuable that nursing perspective is and research and their, contributions in leading and contributing to this type of really important work, and our focus on people, their lives, and the importance of keeping that centered in our work. So thank you for that. I cannot believe how fast the time has flown by. I will be remiss if I don't unfortunately close this out. So let me see here. What do I need to do next? Unfortunately, like I said, that'll have to be the last question. As a reminder to our participants, continuing education credits are available. You can scan the QR code that is hopefully on the screen. And we'll also provide a link in the chat. When you leave, your browser should automatically open the survey. So those evaluations and continuing education are provided by FAES. We appreciate their partnership. So most importantly, I want to thank you, Dr. Mujahid. We are so grateful for you making the time today. I learned so much and was so inspired by your presentation. Thank you for sharing your wisdom and your research with us today. So thank you to everyone for joining. You can reach out to NINR at info@ninr.nih.gov with any questions and to stay up to date. You can visit our website. So with that, I'll close out the lecture. Thank you so much.
Thank you for having me.
Bye, everyone.